My name is Sophie Kubasch. I'm working at University Hospital Leipzig in Germany. I'm mostly caring for patients with MDS and AML. I'm very happy to present you today the results of our RELAZA2 trial, which I will present also today at the EHA meeting here in Madrid. RELAZA2 was a study where we investigated if patients with measurable residual disease, which means there is a measurable disease in your blood or bone marrow, if it's possible to treat these patients with azacitidine in a cohort of patients with AML and MDS. And the idea was to include as much as possible patients after allogenic stem cell transplantation or intensive chemotherapy. If patients have been in CR or CRI, which means you have responded to your chemotherapy, and usually you just go on with observation and monitoring. But in our RELAZA2 trial, we did a long follow-up period from month 0 to up to 2 years, measuring this minimal residual disease every 4 to 6 weeks in a peripheral blood. And the idea was to identify a very early sign of a potential relapse within the next weeks and to treat only these patients with a higher risk of relapse where we already detected MRD. This is the abbreviation for this minimal residual disease. And these patients received azacitidine. This is a subcutaneous injection for the first half a year, and then we decided if they responded, then we were not able to measure any MRD anymore. If not, they still had some MRD, but maybe not that high like in the beginning, and then we adapted the dose. And patients received treatment for up to 2 years at the end. And we were able to show that after the first 6 months, 65% of patients are still alive without any signs of relapse. We also showed that patients with a deeper response, we called it major MRD response, had a better relapse-free survival and overall survival compared to all other patients who didn't respond to azacitidine and also had maybe only a minor response. We also showed that patients with a long sustained response, this have been from the initial responders, 25% had a long-term response. We saw that especially in patients with a very good response, they sustained their response during the follow-up period for more than 2 years, which is very promising. And it shows us that we can prevent or delay a recurrence of the disease. We call it relapse. Also, we could show that patients without any sign of a recurrence of disease, we call it MRD negative, had still a very good outcome compared to every other patient without any recurrence of disease. We were also able to show that patients with a long-term response during our follow-up period for more than 23 months were able to stop AZA treatment. Most of the patients were able to stop it, and we can say that they stopped already more than 20 months. So they did not develop any relapse, and they stayed without any hematological relapse and alive. We can also say if patients initially responded to the azacitidine treatment but again developed MRD or maybe in relapse, we were able to show that azacitidine was able to delay this hematological relapse for more than 13 months. So patients did not already relapse at the beginning, so we were able to show that patients had no relapse for more than a year, which is also a very good result. And also safety of this azacitidine therapy was good. No new safety results came up. It was in line with other prior therapies and studies. So I can sum up that we could show that azacitidine is effective and safe in patients with a very small kind of disease. We call it measurable residual disease. We were able to show that patients responded to treatment, and we were able to delay this potential relapse. This is promising, and therefore we can underline that a regular MRD assessment to see if patients have this kind of potential relapse is important for our patients to make sure we don't miss a potential early hematological relapse and we can give them this azacitidine treatment.